we have basic sciences and then the clinical aspects of cardiovascular disease, you know, and this is complementary and very important, especially for, I would say, the people that are in their younger or earlier years of the practice of medicine. I think that some of the basic science people are coming here, which is a very good thing, and I would like to have that happening more. Today we have cardiology, talking about a very interesting topic, ST elevation, and also cardiologists, you know, they are wise and want to keep us healthy, and they know the benefits of diet, because so today we don't have food, but we will next time, okay? So, great. So we are really thankful and appreciative that you joined us. Okay, Pavan?
Yeah, hey. I hope you can you hear me? Everybody, good afternoon. Thanks for coming. I'm Pavan Katikaneni. I'm the Interventional Cardiology Fellow. I'm glad to be here to talk about a topic that we in cardiology deal with quite frequently. But I chose this because I was told that this is going to be a mixed audience here today. Not just cardiology people, but in fact people, radiology, some surgery, some medical students, basic science, and even a lot of non-clinical folks too. So when we talk ST elevation in the cardiac field, and that's the ultimate in terms of an emergency and the acuity of need and the scare with which patients present, and the way we manage them is a lot more aggressively than we do with a lot of other things. But ST elevations, they're not always the same. They're not always caused by an acute plaque. They're not always caused by acute ischemia. So we have seen some interesting cases in the last few months. So we had put together a few of those, and I thought I'll share it here with the audience. Now, totally unrelated to ST elevation, you know, cardiologists, we like to look at things differently. We like to look at the heart differently, diagnose things differently, and EKG is our first nuclear weapon kind of a thing when we go in with anything. Just throwing to the audience, this was a question that I was doing a board review for the internal medicine residents. Anybody? I'm sorry? See? Okay. One of the residents said, well, I don't even want to think, let's just get an x-ray. He was not a radiologist, he was a prelim resident, and he was right. Why bother about all these things when we can rule it out with an x-ray? But that was fun, just some trivia. So this is, you know, the precordial leads. If you look at it, you see the reverse progression. A normal EKG, your QRS forces go the other way around. This is a reverse of it, and then also your limb leads. And I don't want to go into the nuances of EKG reading and show off here, but that was dextrocardia. But we're here to talk a little bit about an introduction on acute coronary syndromes, and this is data from 2007-2008. The incidence seems to be increasing. A lot of cost attributable to cardiovascular disease, particularly this. And if you talk about ST elevations themselves, they contribute about close to a quarter, 1/3 to a quarter of the total acute coronary events. And the basic pathophysiology, we all are probably aware, is related to plaque instability, the plaque rupturing, causing ulceration, exposing the endothelium and the coagulation cascade being activated initially with platelets coming together, aggregating and releasing the vasoactive substances, causing the fibrinogen activation, cross-linking, forming the thrombin plaque, and then finally the red blood cells going in there and causing a big clot, which basically causes myocardial ischemia and then causing myocyte damage. Now, in terms of a clinical spectrum, it doesn't happen overnight. Most of the times there's a gradual progression of the disease process intravascularly until you come to a point where the unstable plaque ruptures and gives you the ischemic discomfort, causing an acute syndrome. And when this is a partial occlusion with some blood flow trickling down, usually we get the non-ST elevation myocardial infarction. And when you have a completely occluded thrombus causing an acute ischemia, you get an ST elevation. That's the main difference. So basically, we have a complete occlusion. Now, in the cath lab, when we take patients down and we start doing angiography, this is just an example of an acute occlusion with thrombus in a patient. This is your left main coronary artery with the catheter sitting in there. And this is the left anterior descending, the main artery of the heart. As you can see, there's an old stent, and that's completely occluded with thrombus. And that's what gives the patients the ST elevation, myocardial infarction, and we rush and we revascularize. Another example, this happens not just in your native coronary arteries, but it can also happen in your bypass grafts. And this is an example of a patient who had Thank you. Sorry about that. So this is an example of a patient who's had a previous bypass, coronary artery bypass. And you can see an saphenous vein graft that is going down to his right coronary artery. And as you can see here, there is a big filling defect with slow flow and a thrombus here. And that is causing the ST elevation in this patient. So different clinical scenarios. It can happen in a naive patient who never had coronary disease before, and it can also happen post-bypass. And in our evaluations, of course, apart from the ST elevation on EKG, it's also the cardiac biomarkers that help us assess the extent of myocardial damage, the extent of myocardial involvement. And troponin, as you know, every time anybody comes into the ER without chest pain, anything, we get a troponin. And the reason it's important is the magnitude of the elevation of the biomarkers portends and predicts the risk of future mortality for these patients. So along the x-axis is the concentration of troponin, and as you can go up, you can see that the percent mortality at 42 days keeps on going up proportionately. Now, for the non-cardiac cardiology folks, it's troponin, while it is mostly related to cardiac issues, thrombus and ischemia, there are a lot of non-ACS causes of increased troponin elevation. And this is a significant proportion of admissions that come into the emergency room, sometimes just plain sepsis, secondary myocardial increased oxygen demand in a person who is septic, sometimes people who are in renal failure, end-stage renal disease, people with an acute pulmonary embolism, simply just having a hypertrophied heart. Any of these things can cause a baseline troponin elevation to actually keep going up. So these are all things that non-cardiologists and every internist or any physician who sees a patient should keep in mind when evaluating this. Now, again, just wanted a brief recap of medical school. When we are talking ST elevation, you also look at reciprocal changes. So opposite, if you have ST elevation in the anterior leads of the heart going from here around here, you will have a reciprocal ST depression in the inferior leads of the heart, and vice versa. So these are things that we use as a tool to identify which area of the heart is probably involved in a current acute coronary event. Now, of course, when we see ST elevation, the first thing that runs to our mind is thrombus, and we run and we think about achieving the door-to-balloon time to establish reperfusion. But we'll be surprised to the number of times we would have gone to the cath lab and whoops, it's not a thrombus, there was something else that was going on that we missed the ball. And the reason is there's a lot of other things that can cause ST elevation on an EKG in a patient presenting with chest pain. And these are difficult to diagnose sometimes unless we pay very close attention to history, presentation, and the correlation of symptoms and the way the clinical picture is. Things that can kill them, of course, are aortic dissection, and dissection involving spiraling down to the root, involving the coronaries, a PE, a gastric ulcer which ruptured, a simple inflammation of the surface of the heart, the pericardium, or even the muscle of the heart, the myocarditis, Takotsubo syndrome, which is called a stress-induced cardiomyopathy, where you don't have any coronary disease. Brugada, again an electrophysiological diagnosis and disease, but an arrhythmia proponent of this syndrome. Tension pneumothorax, hypothermia, hyperkalemia. So all of these things can cause ST elevation. Now, in general, the treatment goal, I would not go into details of all of this, but basically you are trying to reduce the myocardial oxygen demand when we see somebody, restore reperfusion, perfusion as quickly as possible, and supportive therapy and treating complications. And we go with an aspirin. We try to hit the coagulation cascade at as many different levels as possible. You want the platelets inhibited, you use aspirin, and then the ADP receptor antagonists, the thienopyridines. Then you supplement oxygen, vasodilate with nitroglycerin, treat the pain, anxiety, then anticoagulation with your all the different kinds of heparin, low molecular weight, generic heparins, and also the glycoprotein 2B3A inhibitors. All of this come under this. And then the actual act of reperfusion, either by PCI or fibrinolysis. Now, the reason it becomes important is the acuity with which we need to take these patients down to the cath lab to reperfuse or do fibrinolysis. And this tells you why. The amount of myocardium that you can salvage, this is the area under the curve depicted in this graph. As you can see, with time, as you lose time, even just by a few hours, the amount of myocardium that you can salvage drastically decreases. So that is the reason why when you have an acute ST elevation with 100% occlusion of blood flow, it becomes important to meet the established door to reperfusion times. And this is the logic behind why the acuity becomes important. Now, which is better, doing fibrinolysis, thrombolytic therapy, or actually going and doing an intervention? Several studies have been done, and ultimately the judgment is that if possible, when feasible, and when there is no contraindication, and if available, PCI, or which is percutaneous coronary intervention, is the better one in terms of decreased incidence of death, long-term morbidity, and even more long-term effects. So if a patient comes to a hospital which is capable of doing a PCI, we rush them and do the PCI. If not, you have to evaluate the contraindications. If present, then of course you cannot thrombolize, but if not, we advocate giving thrombolytic or fibrinolytic therapy. And once the patient is stabilized and you are comfortable that the patient is stable for transfer, the current trend is to immediately ship them off to a facility which is capable of taking care of these patients. Having given that background, that's the scenario with which we see most of our patients, and we take them and we revascularize them. There were a couple of cases that we had seen recently that didn't fit the bill. Now, this is the first lady. She is a 54-year-old woman who had gastric outlet obstruction. Been suffering with it for several months now, and in fact I was told that she was NPO for almost 2 months prior to this hospitalization. She was literally starving, and she had a duodenal ulcer that was refractory to medical therapy. Conservatively, they could not manage her. She came with intractable nausea, vomiting, abdominal pain, and as you can imagine, significantly dehydrated intravascularly. Now, she had an EGD prior to presentation, and even at admission, they've seen tight stricture in the duodenal area. They could not even advance a scope, and was told that this is not amenable to any kind of endoscopic intervention. Now, supportive therapy was started. She got a PICC line, total parenteral nutrition was started. 2 days later, she was having significant chills, shaking, and blood cultures, infectious disease workup was started, and the PICC line, the peripheral line, blood, everything started growing gram-positive cocci. So she was being treated appropriately, the lines were out, and then unfortunately she also developed a UTI with gram-negative rods and started on ciprofloxacin. Very unfortunate course. Now, it took her a week or 10 days to recover from this onslaught of infection and the stress of being hungry all this while. Finally, she was taken to the OR, was stable enough, and to undergo laparotomy with lysis of a lot of abdominal adhesions, and underwent a truncal vagotomy, antrectomy, and a Billroth tube procedure, and was reanastomosed back, got a jejunostomy tube, and just reading the whole op report, it looked like she's been through tremendous amount of onslaught physiologically. Under general anesthesia, and surprisingly she did well. She, according to the op reports and the intra-op communications, no acute events. She did well intra-op. Now she comes back to the ICU post-op day 1, and she's not looking very good. She's looking sick. She became tachycardic, the blood pressure was dropping, the urine output was dropping and not even making 10 cc's of air, 10 cc of urine, and then of course supportive therapy, everything appropriate was done. Of course she was dry, so give her fluid challenges, a lot of fluid boluses, albumin. Well, it was not helping matters. Then pressor support, levofed didn't work, dobutamine did not work, and then now with all the fluids and everything, and she suddenly started becoming hypoxic. The lungs were crackly and the chest x-ray looked ugly, and she had interstitial pulmonary edema. Now, at that point, somebody got an EKG and said, oh, well, this doesn't look like the EKG that she had 3-4 days ago, and so let's check a troponin, of course. And then the troponin is elevated at 4. So immediately cardiology was called, and what we had at that point was an old EKG 4 days earlier. It looks pretty normal without even spending much time, nothing really that screams. Now, what the resident was communicated. Now, this is a representational EKG. I could not get the actual one, but the patient had ST elevations which were all over, all across the anterior leads. These are your anterior leads, V1, V2, V3, V4. The inferior leads, 2, 3, AVF. You can see diffuse ST elevations with anterior coving. Now, sometime later, an EKG was repeated, and then for some weird reason, the ST elevations had now resolved, but with new Q waves that were present. You can see Q waves are a sign of infarction or myocardial damage. So you can see new Q waves in the inferior leads that reflects the inferior surface of the left ventricle supplied by the right coronary artery, the anterior Q waves. So now we had somebody with acute EKG changes, a troponin elevation, and post-op, and now you're screwed if you do, screwed if you don't kind of a situation. Do we take her to the cath lab, give her more anticoagulants? How is she going to do if you give her more heparin and integralin and all these things? But in the end, she was looking so sick that she could die from just the shock of it. So a decision was made in communication with all the surgeons, and everybody agreed, let's just take her. Benefits of risks and benefits, and so she was taken, put on full ACS protocol. Echo was done at the bedside without going in. It was not good. The heart was barely pumping and moving, and ejection fraction was about 10 to 15%. So she was rushed. Now this is the information that we had. As you can see, this is an echo that was done. You can see this is the orientation. This is the right ventricle of the heart. This is the left ventricle. The left ventricle opening into the aorta, the aortic valve. The left atrium, the mitral valve. This is the scheme of events here. Even without being a cardiologist, you can see basically the heart is basically barely wiggling here. The only thing that seems to be doing anything little is around the base of the heart here with some constriction here, but the rest of the surface of the heart is not doing very well. Now, another view of this is called the apical four-chamber heart. We basically put the transducer here and just look at the heart. So you have the left ventricle, the right ventricle, the interventricular septum, right atrium, left atrium, interatrial septum, the mitral valve, the tricuspid valve. That's the orientation. Again, you can see very clearly that the whole heart is globally severely akinetic to dyskinetic almost. And then the only thing that's moving is the base of the heart that's doing a little bit. This we knew going in, and it was not looking good. And the angiogram. Well, looking at the echo, we thought, oh boy, there must be something really bad proximally in the left main or the left anterior descending, because to cause so much global wall motion defect, we needed some big lesion. But surprisingly, as you can see, this is the left anterior descending artery of the heart. This is the circumflex artery of the heart, giving rise to branches. We could not see a single flow obstructing significant lesion. So this is a woman in cardiogenic shock who had ST elevations, profound wall motion abnormality, the heart barely wiggling except the base, but pretty much non-obstructive mild disease, nothing that could attribute. So this was really out of proportion. Another view, some mild luminal irregularities in some of these, but again, the major vessels of the heart were fine. Now, the right side of the heart, the right coronary artery, this looks good too. And in this view, you can even make out that the base seems to be moving, the rest of the heart is hardly doing much. Now, we did a left ventriculogram with a pigtail catheter, just shooting the dye there, and you can see clearly that the base of the heart right here is squeezing, but the entire remaining surface of the heart is basically not, it's gone. Now, this is something that we look forward to when we read in patients who have stress-induced cardiomyopathy. But this is the Takotsubo, one of the differential diagnoses in ST elevation. So this was suspected once we saw this classic picture where the apex is ballooned out and the base is wiggling. Now, the patient, we decided, needed only supportive therapy. There's nothing much to offer at this point except medical and supportive care, and wait and hope that this is true and that this will recover by itself if you aid them hemodynamically. Unfortunately, she goes back and a day later goes into severe respiratory distress, was really having increased work of breathing, so she needed to be intubated for support, was on mechanical ventilation. Dobutamine was continued to help with the pressure support. She was being diuresed while at the same time being on that. Did not do well. We had to bring her back to the cath lab again 4 days later because she needed more support. So an intra-aortic balloon pump was placed, and she was having these massive pleural effusions. That was not helping matters. So they thought, let's just get that fluid out, and a chest tube was placed in an attempt to improve the lung oxygenation. So every possible way to optimize the body's hemodynamics was done. And finally, after 7 days or so, she was close to extubation and was weaned off pressure support. Well, of course, nothing goes to plan, so she developed diarrhea with C. difficile positive and then had to be treated again with flagyl vancomycin. And for a few days she was doing well, and I did not follow this at this point, but apparently again she developed a complication with decreased urine output, and this is when radiology was called into the picture, and the CT showed that she had a partial infarction of the left kidney. And there was nothing much that could be done but conservative therapy for that too. And finally, after all this, she was able to be transitioned into oral medications and gotten off on optimal congestive heart failure therapy and was discharged to an LTAC. She was in the hospital for a good 1 month at this point. And finally, thankfully, she recovered to a point where she could be discharged. And the heart was still weak. Echo repeatedly at that point was still barely 15–20%. And we were disappointed in a sense that after 2–3 weeks we thought she should improve, but she was very weak. So we wanted to bring her back into clinic and see how she was doing, and she just came back a couple of months ago. And this is her heart now. And total recovery, complete recovery with a good squeeze of the myocardium. Ejection fraction is normal. And look at the difference from the, if you can remember the previous one, it's totally recovered. So now she has a completely normal ejection fraction, EKG, T-wave inversion. So this was indeed, as suspected, a lady with stress-induced cardiomyopathy or Takotsubo cardiomyopathy. I was reading it up. Takotsubo apparently means an octopus net, and this was seen in Japan initially, and it looks like a net to catch the octopus, the apex ballooning, so that's why they named it. And it is reversible. That was a good thing about it. And from what we know of this syndrome, it is stimulated by emotional stress or even physiological stress. And a lot of an interesting area for research in centers that are high volume who see more of these cases. They're compiling case reports and stuff to see studies to see if there is anything more that they can identify as a common precipitating factor in these patients. And from a clinical standpoint of view, it mimics a myocardial infarction, but we can know that it has a good prognosis. The patients recover well and do better eventually. Sympathetically mediated, that's the suspicion, but the number of possible mechanisms have been laid out. Could be because of some acute plaque rupture and transient coronary thrombosis that somehow vanishes. Doesn't seem that plausible, but it was laid out. Could be simple, significant, profound epicardial spasm that was not witnessed but again, reversible, maybe. Somebody with intraventricular cavity obstructions or basic microvascular dysfunction. I, for one, I think tend to believe that this is microvascular dysfunction probably, and maybe sympathetically mediated, but downstream event must be this, but who knows. And then direct catecholamine surge mediated myocyte injury, which is so acute that eventually the body recuperates and the myocardium heals and the blood flow is reestablished and the patients go well. There's different variants, you know, the apex being ballooned out, sometimes the mid-chamber ballooned out, sometimes the basal. What we saw was an apical variant of this. And the clue is EKG will not be localized to any particular distribution, and there is no coronary thrombus that we see. And so for diagnosis, basically you need a coronary angiogram and a complete recovery of systolic function to be documented to be 100% sure that this is what this is. And fortunately, we were able to do this for our patient. So that was one of the ST elevations that we dealt with, and fortunately for the patient, she did well. Now, another lady, 49-year-old woman. Now, this one had a history of invasive ductal cancer, being followed by oncology for a while now, had a mastectomy and was on chemotherapy. She had a history of hyperthyroidism, had radioactive iodine ablation, and her cardiac history-wise, she had a heart cath that was done after she had an episode of ventricular tachycardia, refractory arrhythmias back in 2010. Heart cath did not show much, but she had an ICD placement for that. Now, the reason she came to the hospital now is fever for 2 days, and she reported that she received a last dose of chemotherapy 2 weeks prior to arrival, and she was on antibiotics, antivirals for shingles, and she had similar admissions in the past. She's not neutropenic, strangely, and in the past for this fever, they could not find any source of infection. Now, like I said, this is again all in hindsight. When you looked into the history, she had symptoms of chest pain going back to 2009. Nothing much was really found. She had a heart cath. Well, there may be some disease, non-critical to critical, could be nothing, but nothing was done. 2010, she had ventricular tachycardia, VT arrest witnessed, and so she qualified to have a defibrillator for future prevention. Heart cath, including an intravascular ultrasound, was done at that point, did not reveal any obstructive lesions. Echo initially had some compromise in ejection fraction, but again improved completely, and she had a history of AFib. She was on cardism, or calcium channel blocker and beta blocker at that time. Some modifications were made, and she was left on metoprolol, and these are current medications prior to coming into the hospital. They thought that long-standing untreated hyperthyroidism could have been the reason for these arrhythmias, and that is known to cause left ventricular dysfunction and heart failure. So that was attributed to endocrine problems. Now, like I said, she was on chemotherapy with extensively being followed by hem-onc. And again, this is all in hindsight when you go and try to put everything together. There were mentions when she would go for chemotherapy and she was reporting pain in the left side of her chest, neck, arm, on and off episodes, last for a few minutes, spontaneously relieved, not associated with exertion or any stress that we typically associate with our typical angina, effort angina. And in fact, one of her chemo sessions was stopped because the oncologist was feeling a little uncomfortable with the way she was describing these symptoms. Now, she was referred to cardiology. She was waiting for her appointment, and then all this happened, of course, and then she came back with fever. Now, she was 103, really warm, tachycardic, workup for sepsis, infection, broad spectrum antibiotics. She was on supportive therapy. Blood pressure was on the lower side. I think systolics of around 100. So naturally, her home medications, the ACE inhibitor, the lisinopril, the isosorbide nitrates were held, and she was continued on metoprolol, just in case. Now, 3 a.m., chest pain, left-sided, classic nausea, vomiting, diaphoresis. The resident goes, talks to her. She says, this happens 3 to 4 times. This is not something unusual that happened today, but looks like the symptoms that I had when I had the ICD. EKG did not show anything, chest X-ray, oxygen sat, everything else looks good, and they got a troponin, CKMB, and all these things. Initially, everything looked good. They even looked at a CT to rule out PE for atypical presentation causing something like this. Again, every 1.5 hours or so, she kept on having the same symptoms. And the physicians would go to evaluate her, and by the time the nurses were called, everything seems to have subsided. Now, they looked at the EKG, the old EKG, nothing really screaming at you, some non-specific T-wave inversions. The EKG that morning, again, really, when we look at these things, we would think, yeah, this looks pretty normal, no acute changes. Now, 10:35, again, boom, the chest pain, left arm pain, nausea, incontinence, and she's hypotensive, and obviously she's crashing. So the core team comes in and she becomes pulseless, unresponsive, respiratory failure, and somebody was looking at the cardiac monitor and they said, oh, this looks all weird and vague, so basically probably must have been some ventricular tachycardia or even VFib, who knows. And then they noted diffuse ST elevations on the EKG. So she was intubated, shocked. The ICD itself was noted to shock her because she already had a defibrillator, so it was picking up the ventricular fibrillation. And then a repeat EKG was gotten. The first EKG that they saw was this, profound ST elevations all over. Again, no specific distribution, as you can see. Now you can see this here, the whole anterior precardium, lateral, inferior, everywhere. You have these tombstoning profound ST elevations. Now, by the time the code was over, they repeated an EKG. Within a few minutes, complete resolution of that ST elevations. They were gone. And fortunately, they were able to record this on paper. Previously, all through the years when she was coming and giving this, she was not fortunate to have that documented. Now, cardiology was there immediately. The lab was activated. To control the arrhythmia burst, she was treated with the antiarrhythmic, the lidocaine, and also amiodarone and pressor support taken to the Cath lab. And of course, we thought, looking at that profound ST elevations, something should be there this time. And what they found was this diffuse significant spasm of the left main, the distal left main, and also the proximal left anterior descending. It was diffuse, it was severe spasm, compromising flow. And that, now thinking about it, explains why she has these intermittent episodes and intermittent hemodynamic instability, intermittent symptoms, and also the electrical changes on EKG. And this is the reason. Now, immediately, promptly, she was given some intracoronary nitroglycerin, and look at that. So she improved immediately, responded, the left main dilated. So this was again profound coronary vasospasm causing ST elevation to the extent that the patient crashed and was having ventricular arrhythmias. So really did well, and at the end it was monitored and she did well. Now, thought it was over. Okay, well, now we find the cause. It is spasm, so now we have to obviously treat her with nitrates or calcium channel blockers or something to prevent this lady from going back into spasm. She needed some hemodynamic support. She had an intra-aortic balloon pump that was placed. Now, we thought it was good, but unfortunately, reading through, she had again ST elevation again, and Dr. Akush is here, he was in the lab. ST elevation again on the monitor, and then again degenerated into ventricular tachycardia, VFib, and again defibrillation. So you can imagine the scene in the Cath lab. This is not fun times. Now again, she was started on a lido drip, nitroglycerin to contain, and you get the EKG. Again, the EKG is again stone cold normal. She goes back and to the ICU, and we know what we are dealing with, and we were trying to support with the nitroglycerin drips and also the pressor support with the balloon pump. The plan is to titrate the nitrates and avoid beta blockers that could potentiate vasospasm. So that was the plan, but obviously she had already gotten it and it was in her system. It's going to take some time for the effect of that to wane off and the nitrates and the calcium channel blockers to pick up. She had a few more episodes and a lot of anxiety for the fellow on call and the residents and everybody every time. This is a never-ending process. Slowly, she was transitioned into oral nitrates, oral amiodarone, and she really improved significantly. Now, this is what we called the variant angina. The symptom is the variant or the Prinzmetal's angina. We read about it a lot in textbooks and cardiology books and also medicine books. Probably even see them, but may not have identified a lot of them. Patients do probably describe this, and sometimes we discount them because of the atypical history, and sometimes the medicines itself that we inadvertently put take care of it. But very occasionally is when we actually are able to catch it, document it, and then know exactly what's going on. And the typical things about this from a clinical point of view is that they are at rest, no association with activity. They are usually early in the morning, really like it happens in the movies, in the early morning, early surge. That seems to be the time physiologically when the myocardium is on the coronary vasculature bed is at risk of developing the spasm. Lot of times associated with the ST elevation from the case reports triggered by the spasm, and usually in the absence of any morphologically evident high-grade stenosis. I use those words because we are not sure exactly if there is something microvascular going on. And again, they're usually localized, but sometimes it's very diffuse and causing hyperreactive segments. That's pretty much what we know from a basic science standpoint of view, an interplay between the vasoreactive stimulus to endothelial dysfunction to again a catecholamine surge. So that's the theories that are out there regarding this. Now, from a clinical standpoint, always ask the patients if they were on any of these recreational drugs. The cocaine, marijuana seem to be the main ones that, of course, cause the spasm commonly. But that seems to be slightly different as a clinical picture, but they seem to be more susceptible, people who drink and use the ephedrine-based products. And we notice spasm quite commonly when you are intervening in the coronary arteries. Every time a coronary wire goes in, or sometimes the balloons, you irritate the endothelial cells and then you cause it, but it's usually reversible. But magnesium deficiency, all these. So evaluation is usually clinical, and diagnosis is by having an extended ambulatory EKG monitoring the loop recorders that seem to be doing it. And sometimes you will probably need to actually provocate and incite spasm while you are doing the heart cath by actually injecting ergonovin intracoronarily, or even acetylcholine and cold stimulation, hyperventilation, a lot of provocative tests that are tried in the lab to see if you can recreate this. We did not need to do it in our patient, but that might be necessary for a diagnosis. And like I said, it's usually overlooked because it's a fleeting diagnosis. And the important thing is the fact that even though this comes and goes, people can just die, they drop dead, sudden cardiac death. So this is probably one of the contributors for sudden cardiac death that never make it to the hospital, and we don't know what happened to them. So many people believe that this could be a significant chunk of those patients too here. So prompt diagnosis by paying attention and knowing that something like this is out there helps in identifying them. And the effective therapy is calcium channel blockers, and that's what we did for our patient, and she did well. And angiogram obviously is needed to rule out a fixed defect. And sometimes stress test is done before you proceed to angiogram because the exercise itself can stimulate spasm in people. And I've just mentioned this. So the mainstay of treatment is simple: nitrates, calcium channel blockers, smoking cessation, and some things in the pipeline, the new rho kinase inhibitors and stuff, but probably not made it to the clinical use yet. But they have been shown, the rho kinase inhibitors have been shown to inhibit the acetylcholine mediated vasospasm, so potential targets for future in these patients. Now these are some guidelines I will just skip through. I don't know if we have time, but I had just a small question again. Somebody comes in with ST elevation to the emergency room. You see a good nice clot in the LAD. It is successfully treated, gets a drug-eluting stent. And this is something I thought I'll throw in for the non-residents who are non-cardiology people, but we see these patients on the floor several times. 2 days later, the patient complains of chest pain radiating to the trapezius ridge, the shoulder. And again, you see an EKG, and again, boom, you see this. So you see pretty much diffuse ST elevations. So The patient had an ST elevation infarct, LAD lesion, you stented it, 2 days later chest pain, and this is what we see. So what would you do? You're on the floor, you're called. You would want the patient to go back for an angiogram, or because you're mostly radiology, you would want to get a chest CT to see what's happening, or aspirin or steroids. Anybody? CT? You're thinking dissection? Yeah, it's possible. Now, because we are cardiologists and sometimes we like to show off our EKG skills, again, this is 2 days later after a massive MI. This is when you have a lot of myocardium involved and inflamed and irritated. It's a time for having pericarditis, inflammation causing diffuse ST elevations. So there are some signs that we look at. So the EKG does not follow a particular territorial distribution. You have ST elevation in the inferior leads, which are here. So that is supplied by your right coronary artery. You have ST elevations in the lateral circumflex. So they don't necessarily follow a particular pattern. So you can't really explain involvement of one artery. So that's a clue that this is, and also of course some depression in the PR segments, that this is in fact post myocardial infarction pericarditis, which is quite commonly seen. And a lot of time, this is one of the reasons, one of the confounding things in ST elevation patients. Majority of the times we don't know why they have it. It's just viral illnesses or some inflammation. But post cardiac surgery, post myocardial infarction, and basically with the treatment is anti-inflammatory drugs. And we get these in our cardiology boards, and I know for radiologists probably you already picked it up immediately. This is thrown in there whenever we have a pericarditis case. I don't know who is the guru who compiled this, but this is there in every exam for us, the pericardial calcification in a patient with recurrent pericarditis causing constriction, I am sure. And of course, there's nothing you can do in this situation except do the pericardiectomy. So, but simply pericarditis, it's benign. Usually people recover, but up to 30% of them can develop recurrent, and those are the problematic patients. And usually the treatment is non-steroidals with or minus colchicine. And the important thing is to avoid steroids. If you are in the OR, if there is any surgery residents here post bypass and you see these patients, try to avoid giving them any steroids and then stick to basic non-inflammatory drugs, and they do the trick and the patients do well. So thank you, and thank you. Yep, thanks. Thank you.
I think it was delightful to see your expertise that you represent the section, and it was very clear, very thorough.
Thank you. Yeah, I was not sure. It's a mixed audience, and I know it's an interdisciplinary conference, so we wanted to keep it simple from a cardiology standpoint. Sure, Dr. Kevin.
So, Pavan, from the standpoint of some of us that are doing research in the room, a lot of the work that you, or the clinical conditions, I should say, you talked about, dealt with spasms.
Yes.
How much of this involves a myocyte defect? Because the thing, especially in some of these patients that have sudden death, that the spasm may certainly be contributing to it, but might that also suggest there's some sort of defect with the myocyte that they don't have much tolerance, or they can't handle, because it's not as if it's completely ischemic, is it?
It's not. So
right.
this again, great question, but this is again a situation where which came first, the chicken or the egg? Is it the myocyte itself that is primarily having something pathologic going on that is triggering a response and making the endothelium dysfunctional, causing the spasm, or is it the endothelium being dysfunctional, causing ischemia and stunning and constantly affecting the myocyte into finally giving up? So
when I say myocyte, I'm thinking of the cardiac myocyte,
yeah,
not the vascular smooth muscle cell. So in the coronary artery,
yeah,
that vessel is going to be large, right? And so you're going to have a fair media there.
Yeah.
So clearly the VSM may be able to secrete something that goes and makes into the But still, nonetheless, you're getting that ST elevation, which is coming from the cardiac myocyte,
yeah,
right?
Yeah.
Not from the vasculature. So in that regard, do you think that there's something unique about the cardiomyopathy?
Well, that may be true more Pathophysiology per se, because Pathophysiology shows the EKG changes, my arteries are open and you are Angina. But per se, vasospasm, so it's not just that, it's on capillary vessels too.
Capillary vessels, right.
Per myocyte, you also capillaries. There's also capillary per myocyte.
Yep, yeah, it's huge.
So that's cool. Spasm might be spasm, but it may point to Pathophysiology.
Yeah, I think, go ahead.
So it gets to what we just had, Jeff Frisbee come here from West Virginia, and he was talking about, at least in diabetics, and a lot of groups now are saying that the microvasculature is probably playing a big role, but we don't have any good way to measure or analyze that, right? I mean, you can see it in an animal because you can sacrifice it, but you can't do that to your patient and see it.
CFRs for next reserve or capillary.
Yeah.
That's mommy, but
Okay.
you have to connect patients. That's more stable patients. When they come chest pain, you can CFR, you can give a little point, to use spasm. But that's related to CFR or next reserve.
So do you think then which one maybe is more important, the microcirculation or the macro?
Both probably, because cardio vessels, you don't have that vessel, you don't have microcirculation. Well, even though if you put the cardio, if you put a microcirculation stuff, you still have symptoms. So it's both.
So now actually talking of the coronary flow reserve, and like Dr. Akush said, big centers, they're using that to actually see what's going on. But the dilemma is, in a setting of an acute coronary syndrome, they're not sure if they can translate the result of that coronary flow reserve at baseline. They think that when the person is having a syndrome, basically the endothelium, the entire cascade is all dysfunctional. So any measurements that we may get may not reflect what at baseline the patient is doing. So I honestly, I don't know. So. Right.
Thanks for that.
Yeah, thank you.